Alright, hello. Today I'm going to go ahead and do two videos, one on electrical stimulation, another on ultrasound, hopefully if we have time to do this. The E-Stim videos we're going to cover are going to cover the types of E-Stim that we talked about in class. We're going to talk about IFC and TENS combined, we're going to talk about Russian, and then I'm going to talk a little bit about PreMod just in the explanation how it applies to IFC as well. So we're going to start with IFC and TENS today, right? So we talked about IFC and TENS in the classroom, and IFC and TENS can be used for multiple reasons. They can be used to reduce pain, reduce swelling, reduce inflammation. Overall, the main reason we use IFC and TENS in the clinic is pain relief. So the patient comes in with whatever condition they may have, the IFC and TENS can be used to relieve their pain. The IFC and TENS is going to work on a couple different principles, right? And we talked about this. It's going to depend upon what type of patient you have. So one of the things we're going to have to find out when the patient comes into us, right, is are they a chronic, or let's go with the other way around. Are they an acute or are they a chronic patient? So in the case of that, are they acute or are they chronic based upon their severity of symptoms and time of injury, right? So if they're within the first couple weeks, they'd probably be an acute patient. If they're a longer-term patient, they're going to be chronic. That's going to determine what type of pain relief they're going to get out of it. And that's going to determine the pain relief theory that we work on, right? So if they're an acute patient, we're going to work on the gate control theory. If they're a chronic patient, we're going to work along the noxious stimuli, also known as the opiate release theory. Right? So if we're an acute patient, we're working along that gate control theory. That's the same idea of rubbing your head, right? You bang your head, you rub your head. The idea is you're sending a different signal to block the pain signal that's coming from your head. Down here with the chronic patient, their pain has been existing for a while now. The only way that we're going to improve the pain is by causing a little bit of discomfort in order to trigger a release of natural endogenous opioids, right? This is the theory that if your ankle hurts and somebody punches you in the face, all of a sudden you forget about your ankle because you've released endogenous opioids that's relieving the pain. This is going to help determine our frequency and our pulse width. Our frequency is how often that E-Stim is hitting, right? So pulses per second. Whether it's a high frequency or whether it's a slow, steady beating frequency, right? Pulse width is how long each of those hits come along, and that's usually measured in microseconds. So with the acute patient up here, we want it to hit really fast because we want it to basically be really quickly rubbing their head or rubbing their injured area. So with the acute patient, we're going to have a high frequency. Now, the frequency and pulse width are inverse of each other. So if we're going to have a high frequency, we're going to have a low pulse width. That's an L. And then the opposite is the same for chronic, right? We're going to have a low frequency and a high pulse width. So acute, gate control, high frequency, low pulse width, right? Chronic, when we're down here on chronic, right? We're endogenous opioid or the noxious stimuli theory, right? We are going to have a low frequency and a high pulse width. So with that acute patient, we want it to hit so fast that we don't cause any muscle contraction at all, right? We want it to be just beating so fast that the muscle can't keep up with it. So it's that real sensory level input, right? So this is going to be a sensory level input up here. This down here with chronic, that is an R. With chronic, our goal is to get a motor response. So we're going acute, right? Gate control. So therefore, we're going for a sensory response with a high frequency and a low pulse width. For chronic, we're going for endogenous opioid or noxious stimuli theory. We're going for a motor response With that motor response, we're going to use a low frequency and a high pulse width. We want it to hit, and we want it to hit for a long period of time so we can get that muscle to kind of quiver. So that's the basics of both of them. If you understand that, and then you just have to learn the numbers. Where do I want my numbers to be, right? Your low frequency typically in the 1 to 10 hertz range. And your high frequency somewhere above the 200. So that's kind of, or the 100, 120, depending upon your machine you're using. So that's kind of the thought process behind doing these. If you can get this theory, the rest of it kind of makes sense. If you get this sets you up for 10s, and then IFC, the pulse width automatically set for you, so you just have to adjust the frequency. So that makes things simple for you. We're going to talk about IFC first, right? I want to get my pads over here. So, where are my pads? There are my pads. With IFC, we're going to use a 4-pad system, okay? So the first thing we do if we're working with a patient is we're going to go ahead and clean the skin in the area. We're going to pretend that we're doing IFC to my forearm here just because it makes it easy. We're going to take our 4 pads and we're going to surround the area of pain. So I'm going to say that my pain is right there. We're going to surround the area of pain. We do not want the pads overlapping each other, but we're going to put the pads on the patient first. Once we put the pads on the patient, the next thing we're going to do is do our leads. So we're going to look for our channels. On this machine, this side is channel 1, this side is channel 1 and 2, this side is channel 3 and 4. I'm going to hook my leads up. I want channel 1 to be diagonal from each other. Right? This is going to be challenging for me. I probably should have put these on before. So channel 1 is going to be diagonal across. Remember, with IFC, we want it to be in an X formation. Right? So there's channel 1, then we're going to take channel 2, and we're going to cross it over the other way. So channel 2, we're going to put across this way. Ideally, if the patient has hair like my arm, we want to go ahead and remove that hair as well. Typically, IFC, we're talking about doing the low back, or we're talking about doing the knee, or the calf, or the hamstring, something to that effect. Usually not something this small. If I'm seeing somebody's forearm, I'm going to go ahead and do typically PreMod, which we'll talk about in a bit. We're going to turn on our machine. Right, so our machine is now on. It's testing the sim board. All right, we're going to go choose channel 1 and go into IFC. Now remember, we're going to start with an acute patient. So acute patient, we do not want any motor response. We want a sensory response. So therefore, we want a high frequency to stimulate the gate control theory and a low pulse width. So I'm going to go down to my beat frequency. I'm going to adjust it. I know you can't see this. You're going to have to trust me, right? And I'm going to adjust it. And I'm going to go 100 to 150 hertz. Now, again, if you have my cheat sheet, which I believe Dr. O'Neill had given you, right, which has electrotherapy and stuff on it, on page, I believe it's page 3 of it. Page 3 has 10s, and page 4 has IFC, right? We're going to go with that acute phase, which is the 100 to 150 hertz. The good news is, like I said, once you set the frequency, everything else is set. The scan is used to overcome accommodation. So typically, most clinics will use 40% scan. Some PTs may bump it up to 100% scan in order to overcome accommodation. Once I've got the pads in place, I got my frequency set, the next thing I need to adjust is my time. Your time for this is going to be somewhere between 15 and 20 minutes. We're going to set mine for 15. All right, so I'm set for 15 minutes now. Now that I've got 15 minutes set on the machine, I'm going to start adjusting the intensity. I'm going to ask the patient, please let me know when you start feeling it. So we're going to go up until they start feeling some sort of a tingling. So if they start feeling a tingling, that's where we want to cut it off for IFC. We may adjust it 1 notch up just to get a little bit more of a buzz going on. They're going to say they feel like they have ants crawling on their skin, or something to that effect, or they got like it's going to sleep. Once we've done it, if you look, I've got no muscle contraction going on here. That's what I want. We're going to go ahead and start the machine. And when you start the machine, that's going to shut off briefly, and then it's going to start sweeping. That is what that scan is. It's going to sweep through all the frequency you have. So you have about 50 hertz from 100 to 150, and it's going to sweep between those. Channel 1 is going to sweep at a different frequency than channel 2 in order to cause an interference current. That's what you're doing. You're interrupting or interfering with the signal of pain. Right? So the patient's going to be on this. You're going to want to check on them at about 5 minutes to halfway point. Come back and check. Maybe they don't feel it. Maybe they only feel it in this pad and don't feel it in this pad. You can adjust the individual channels at that point based upon what they're feeling. But make sure that if you're adjusting the channels, you know which channel you're adjusting. Because if I adjust right now, the only thing I'm adjusting is channel 1. So I want to make sure that if I need to adjust channel 2 too, I go down and adjust channel 2 as well. Right? Again, acute patient, we are going on gate control theory. Gate control theory works in the sensory level. We have a high frequency, low pulse width. So we're going to stop this and cancel out of this. Let's talk chronic patient now. With a chronic patient, we do want a motor response, so we're going to work on that noxious stimuli period. So we're going to go back into our IFC, and if you look at your paper, most of it we're going to set on that patient is about 2 to 10 hertz. So we're going to go down and adjust that frequency. We're going to take it down to that 2 to 10 hertz. So again, what that means is 2 to 10 pulses per second, okay? Got everything set up. We're going to set it for our 15 minutes again. This time we are looking for a motor response, so we want the patient to tell us when they start to feel it. And then we want them to know that it's going to get a little bit intense because we want to get that muscle quiver. So we're going to start the machine up. I've already adjusted the frequency. Again, with IFC, the pulse width adjusts automatically. And we're going to go with that same 40% scan. So the patient's going to tell us when they feel it first, right? And then, I don't know if you can see it, but I've got some muscle twitching going on. You can see my thumb kind of moving along with it, right? So I can adjust it up. I want to get a little uncomfortable. There we go. Now we got definite muscle twitching going on, right? So we want to get that muscle twitch going on. Once we've got that muscle twitch going on, we can start the machine. And again, now it's going to start scanning through that area. We're going to get that kind of twitching going on the whole time, right? I am not doing that. We're going to go through it, and it's just going to continually cycle. At about the 15-minute mark, we're going to come back and check on them again. If everything's okay, we let them sit through it. If it's a little too weak now, we may have to adjust that intensity up, right? So we're going to allow that to go for 15 minutes. But again, so acute, we're operating on what theory again? We're operating on the gate control theory, which is a sensory level, high frequency, low pulse width. With chronic, we're operating on the noxious stimuli, also known as the endogenous opioid, right? Theory. We're going on a motor level, which is causing me to kind of twitch out here. And then we're going to go low frequency, high pulse width. I hope that makes sense. Now, we're going to stop this because I don't want my fingers twitching anymore. The only difference really with this between TENS and IFC is the way the pads are laid out, and then whether it's a direct or an alternating current. This machine operates on alternating current. Because it operates on alternating currents, because you plug it into the wall, right? This gets a little bit more juice than your little 9-volt TENS unit, right? So with TENS, the major difference is the way we're going to align the pads. We're going to shut this machine off so it doesn't make all that noise. With TENS, instead of going in the X formation, you're going in an I formation. So channel 1 is going to be in line, channel 2 is going to be in line. You can go channel 1 and channel 2, that's okay. The only area you don't want to cross is back on the spine. You don't want those channels going across the spine. You want them in line with the spine. Okay? But that's the only major difference between TENS and IFC. Okay? For your comps, with TENS, you're going to do low back. You're either going to have a chronic low back patient or an acute low back patient. Either way. With IFC, it's typically what we've practiced here in this school is we've practiced with the knee. And you're either going to have an acute knee patient or a chronic knee patient. You're just going to ask the patient to point to their pain. You're going to put the pads around the pain, right? With IFC, they go in line with the pain. Or I'm sorry, with TENS, they go in line with the pain. With IFC, they cross and make an X. So the point of pain should be in the middle of that X. So always remember, TENS, I formation, IFC, X going to give it to you. That's the way it's going to work. So that's IFC and TENS. We're now going to go ahead and we're going to do a little bit of Russian, right? So Russian is classified as NMES, neuromuscular electrical stimulation, right? So that means we are using electricity to stimulate a muscle response. I'm going to look for my channel 1 here. That's channel 2. This is my channel 1. So the two main scenarios you had on your comps and your practicals for Russian, or 3 total. You had wrist drop, where a patient can no longer extend their wrist. You had foot drop, where they could no longer dorsiflex their foot. Or quad failure, where we're stimulating the VMO, and the VMO is part of the vastus medialis, the vastus medialis oblique, and it's right here, and it's what locks in your knee at final terminal knee extension. So we're going to work on wrist drop today. Wrist drop is going to work with the wrist extensors. So if the extensors are here, that's where they're going to be, right? They're going to be on that lateral compartment of the wrist. The thing you have to be careful of with the wrist extensors is you can end up on the brachioradialis and end up with elbow flexion and a little bit of thumb movement as well. Again, I talked to a couple of you, so here's my extensor wad right there, right? There's my brachioradialis, extensor wad. Now don't expect your patient to be able to do that because they may have no muscle mass in that. So you have to know the anatomy of where your wrist extensors are. And just know that they're slightly behind your brachioradialis, right? So for Russian, with Russian, there's not as much to worry about, right? So Russian's job is to do what? Russian's job is to stimulate a muscle contraction. I believe that is on page 2 of your packet. So we're going to do all the normal stuff. We're going to turn on our machine. We've got the pads in place already. So the goal we should get is we should get wrist extension. Once the machine circulates and tests the circuit board, we're going to go in here and we're going to choose Russian on the machine, right? So we are on a single channel because we only have one channel. We can do 2-channel Russian where maybe we do a co-contract where muscles contract at the same time, right? Or the other thing we can do is we can do reciprocal. Maybe I've got a weak extensors and wrist flexors. So I could put pads on either, and one cycle will do the wrist flex extensors, one cycle will do the wrist flexors. But we're going to do single channel because I'm not going to torture my arm that much, right? Frequency, we kind of leave it alone. Usually it's between 35 and 50 hertz. The lower the frequency, the more likely you're going to get a good solid contraction, right? The main thing you're going to adjust with Russian is the cycle time. The default on these machines is 10 to 50. That means it's going to be on for 10 seconds and 50 seconds off. That takes a lot of your time up. Most PTs are going to use either 5-5, 10-10, or 10-20. I mean, it's on for 5, off for 5, on for 10, off for 10, or on for 10, off for 20. Most clinics use that. We typically don't use the 10-50, and very rarely you're going to do a continuous where you're stuck in 10. So we're going to do 10-10 today. So we're in 10-10. Frequency's already set at 30 or 50 beats per second. I'm going to adjust that down. We're going to take it down to 35 to that starting end of the frequency range. So there's 35. Ramp time. The ramp time is how long it takes to hit peak electricity. Usually 2-second ramp is the normal ramp. Okay? Again, that's going to be set by your PT and what he wants. A longer ramp time will slow the curve to get to that peak, which makes it a little bit more bearable for some patients. So that depends on your PT's overall decision. Duty cycle, usually 50% is common. I've rarely seen anybody do anything different. So now we're going to adjust this. So we've got the pads in place. They are not overlapping. They're side by side. They're on the wrist extensors. We should get wrist extension. We're going to tell the patient we're going to turn up the stim. We want them to let us know when they first start feeling it. Right? So we're going to go up. Let's see what happens. Patient's going to tell you when they start feeling it. We're going to say, okay, it needs to get a little intense because we need to get a contraction. There we go. We got a good contraction going on. I want a little bit more out of that. There we go. Nice, good wrist contraction, or wrist extension. You can see the muscle quivering a little bit up here, so we're going to go ahead and start the machine. As soon as I start the machine, it's going to shut off. And then it's going to start firing and pull my wrist up. And we're going to stay with them through 2 cycles of this. So it's going to hold for 10 seconds, and it's going to shut off. It's slowly shut off. There we go. I am letting my wrist be completely dead. I'm not doing anything here. So it's going to be off for 10 more seconds. We're going to let it go for 10 seconds. And it's firing again. Right? There it is again. And after 10 seconds, it lets it go. So now on the third, we want the patient to contract with the actual E-Stim. So we're going to tell them, okay, on this next one, I want you to go ahead and contract and pull that hand up to the sky with me. Pull, 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 pull. And they'll find is when they're pulling on that and doing as much as they can, it lessens the intensity of these pads up here. Right? So pull, 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 and then relax. And we're going to go through it. You're going to go through how many ever cycles the PT has ordered for you. Typically, the PT is going to order you on a number of contractions. So they may say cycle time, or a duty cycle of 10-10 for 50 contractions. At that point, you have to know that we're doing 10 seconds on, 10 seconds off. One cycle takes 20 seconds. That means you have 3 cycles per minute, 20 seconds, 20 seconds, 20 seconds, 60 seconds. If you have 3 cycles per minute and you want 50 contractions, you've got to divide 3 into 50 and get the number of times you need to do it, right? So 3 into 50 is going to go about how many times? Do the math yourself there, right? And that's the way you're going to set the time then. You always want to set the time a little greater than the number of contractions you have, because you may get those 2 base contractions and those don't count for those 50 contractions. So the contractions count once they start contracting. So we've gone over IFC. IFC matches up with TENS. The only difference is the direct versus alternating current. We just covered Russian. Russian is NMES, neuromuscular electrical stimulation, in order to contract the muscle and cause a contraction. The last thing I wanted to mention, we talked about high volt for pain or for wound healing. We already talked about that. Is PreMod. PreMod is pre-modulated IFC, meaning that the modulation is already set in it, so we don't need forked pads for it. PreMod allows you to do the same modulation with only 2 pads. That's beneficial for small areas. If you've got a patient that you're working on a small area, such as an ankle or a wrist, you're not going to be able to get 4 pads around this. You're going to need to do PreMod. PreMod only requires, again, 1 channel, which is a bonus, because you can then hook up somebody else, PreMod, to channel 2, and therefore you can theoretically have 4 patients hooked up to this unit by itself. So that makes things a little bit easier, right? But PreMod doesn't get as deep and it doesn't get as intense as true IFC. So if you're working on the low back, you probably want more pads because the low back is a much larger area. But if you're doing something like the wrist, 2 pads is sufficient. You can probably do PreMod IFC. I hope this video has helped. If you have any questions, please go ahead and send me a message. Thank you very much.